Welcome everyone to today's webinar, Build It and They Will Come, Your Path to a Sustainable Telehealth Future. On behalf of Becker's Healthcare, I'm Erica Carvajal, and thank you so much for joining us today. Before we get started here, I'm going to walk through just a few quick background notes. So we're going to begin today's webinar with a presentation, and there will be some time at the end of the hour for a question and answer session. So you should see a Q&A box on the right side of your screen, so you can go ahead and use that to submit any questions you have throughout the webinar by typing them in there. The session is also being recorded, so it will be available for viewing after the event. You can access that once it's available using the same information that you used to log into today's webinar. And if at any time you're not seeing your slides moving or having any audio problems, try refreshing your browser, and you can also use that same Q&A box for any technical questions you have, and we're here on the back end to help out with those. So with that, I'm pleased to welcome today's speakers. First, we have Kurt Mosley, the Vice President of Strategic Alliances at AMN Healthcare, and as well as Mark Knudsen, Head of Telehealth Technology Solutions at AMN Healthcare. Mark and Kurt, thanks so much for being here today, and I'll go ahead and turn it over to you now.
Well, Erica, thank you, and welcome to everybody on our webinar today, Build It and They Will Come. And for my colleague, Mark Knudsen with AMN, we're happy to be here with you. And I wanted to say good afternoon to everybody in the Mountain, Central, and Eastern time zones, and good morning still to people on the Pacific time zone. We're happy to be here with you. And let me just briefly go over the agenda today. First of all, we're going to talk about an overview of the drivers behind telehealth and its delivery models today in America. We're also going to hit on the hybrid healthcare model that we're seeing today, which is sort of a combination of inpatient or office visits, if you will, combined with telehealth. We're going to do a slight overview of flexible staffing and how it developed, why it developed, and what the future looks like. We're going to also address functionality and features of these different delivery systems and how they work, and get into maybe some of the nitty-gritty behind them. And then what's the real telehealth solution look like? Well, it's the one that's best for you, your patients, and your providers, and we'll discuss that. And then lastly, we want to address something that we feel is very important, is our chronic care in America and our chronic care patients. Currently in America, we spend about $4.2 trillion a year on healthcare, which is the highest we ever spent. It's edging close to almost 20% of our gross domestic product. But within that, and I want to talk about this just very briefly, if you look at half of the healthcare spending, $2.1 trillion, is attributable to 5% of our patient population. Let me say that again, 5% of our patient population accounts for half the healthcare spending. And we want to also address how we think telehealth can help that, reduce those costs, and help us offer more healthcare to the people that need it in America, and then reducing hospital readmissions. So really, what are the key drivers of telehealth and the rise? And everybody says it's COVID, but it really centered on the HITECH Act of 2010. That's when everybody was not pushed, but just, we were asked to take from our, written notes, our written papers, our written charts to go over to telehealth or electronic health records. And just think about the evolution and improvements in technology. I mean, think about the first telehealth in America was really during the Civil War, and they used communication systems like the telegraph. I mean, that was the biggest innovation during the Civil War, and it was really sort of a telehealth initiator where they would radio ahead or telegraph ahead, how many wounds they had, how many wounded were coming. And you just think about that, how we went from Morse code to now us visiting today in America, talking to over, estimate 500 people that signed up for this all across the nation. So just think about that. It's very similar to what our people always call a moonshot. What was a moonshot? Well, it was 1961, 15 minutes in space, and 8 years later we were standing on the moon. So again, it's going fast, it's rapidly advancing, and really COVID was one of the drivers behind it. And again, CMS changed the system to enable greater reimbursement for our providers, which they accepted, and also the Great Resignation, the provider shortages, which we'll discuss. And consumers also, once they got a taste of this, consumers were real leery about receiving telehealth, telecare, if you will. But again, when somebody started saying 8 members of my family had it for the first time, they said, we're never going back. And I think we're over that hump. We're over we've crossed the Rubicon, so to speak. and then also increasing provider willingness to use telehealth. And we'll discuss this later, but that increasing willingness is tied into fair and equal compensation for seeing people in person, whether they're doing it or virtually. And changing attitudes. I think it's very important. 64% of providers are more comfortable using telehealth today, and our consumers, about just under 60%, 40 to 60%, excuse me, want a broader set of virtual care solutions. And I think this is very important, and not just a telemedicine visit, but virtual care. My neighbor, I talk about my 4 neighbors a lot. I live here in Dallas, 2 across the street, 2 on each side of me are doctors. And my neighbor was a neurologist, and he went from a plan of 9 months to institute telemedicine to 9 days because of COVID. And he said his patients, once they got a taste of it, wanted more access for monitoring using iWatches, different situations, in-home monitoring. And again, parity and reimbursement, whether it's personal or virtual. And I think here's the key here. People say, is it going to grow, continue to grow? Look at the investments. I mean, the revenue, the investments in digital health and telehealth players almost doubled in 2020 compared to 2019. So it's the here and now, and it's here to stay. And consumers want it. I mean, like I said before, just think about our own system in America for convenience. And we saw a lot of things become what during COVID? More convenient, absolutely. But think 10 years back. What did I mostly do when I was out running personal errands? I went to the bank and I went shopping. So now almost all banking is done virtually, and all grocery shopping now is done maybe through Amazon or any other delivery systems. So healthcare is starting to come along with that. The convenience was always there, and once you get a taste of it, it's hard to go back. But anybody travels on the call today, you know now traveling's, except for the delays in plane flight, but it's more convenient having your boarding pass on your phone, having your hotel key on your phone. So convenience is the here and now. And our system in America now, we want it all, we want it right now. But I think here's the key. 45% of the people 18 to 29 in America do not have a primary care physician or don't want one. They want convenient care. That's compared to only 18% 50 and older. So to take care of this younger population and make sure they get the health care they need at a convenient model, I think the key is to continue offering telehealth. And this we see growth areas. Our older population, which includes myself, was hesitant at first, but I think now they're coming along fine. But it's our younger population, I think it's going to grow this. And again, we have a doctor shortage. I think everybody on the call today will probably agree that we have a doctor shortage in America. The Association of American Medical Colleges predicts up to 124,000 too few by 2034 in America. That's a huge amount. And when you look at it, just back in 2003, the same organization was predicting a 100,000 doctor surplus. And again, they missed, they goofed. Almost 60% of the physicians feel burned out, and we've seen that. My one neighbor said that the biggest thing that burned him out during COVID was he was pit between civil liberties, or the First Amendment, if you will, and public health. Wear a mask, don't wear a mask, don't go out in public. He said we weren't trained for that. And we've seen burnout more pervasive now, even in our allied professionals and our associates that help provide health care. And again, I think, number one, telehealth is going to be what we're talking about today. It's a key to extending the workforce. Again, it helps recruitment and retention. And we've seen so many in our issues now in America when we do in our staffing firms within our company of AMN, psychiatrists are almost all of it insisting on telehealth options to be able to deliver mental health to the issues and to the people that need it in America. And again, a key part of that is the American Association of Psychiatry issued a statement about 6 months ago in a report to the president that 1 out of every 4 people in America has a diagnosable mental disease. So we're seeing that need, and this is the way to get mental health to the people that need it today. And mental health is a key issue, as we all know, because COVID really put us back, not only our adults, but our adolescent patients in America. And then another key, how do you provide more accessible care, more effective care, and quality all at the same time? And again, it's not necessarily doing more with less, but it's doing better with less. And how do you do that? Well, how do you get to this patient satisfaction, higher outputs, increased access? We think a lot it's going to be involved around telehealth. And again, ensure better access, compliance. We can monitor patients better, and interventions needed as we go through telehealth, especially our patients that survive COVID, the care they're going to need afterwards and the aftercare. And then it's just an access issue. In America, time to schedule a physician appointment is increasing dramatically. A survey that our sister company, Merritt Hawkins, did, the time to schedule a new patient day is 26 days, and that's up 8% since 2017, up 24% since 2004. And it's all an issue of access, ladies and gentlemen. And we all know access, healthcare delayed is healthcare denied. We have so many issues in America today with the cost of our healthcare, which I mentioned earlier, due to the fact that patients don't get the healthcare they need in a timely manner, and then it develops into more serious issues and more costly issues as they get on with their maladies. So when we look at all those issues, Mark's going to discuss our hybrid healthcare models. Mark?
Thanks, Kurt. So I think Kurt's done a great job of teeing up the context and all of the drivers that are affecting all of us, whether we're coming at it from a patient perspective or a provider perspective. There's certainly catalyst for change, and healthcare is not always the quickest to change, but there's been a lot of factors that have been forcing that. So certainly the pandemic changed life for all of us, and I think one of the positives come out of it is it really forced the utilization of the technology for communication in the healthcare context that was existing but really was not being utilized. And now that we get to the other side of the post-pandemic, and I know we're all still figuring out what that means exactly, there's the opportunity to think about hybrid care, which is really how do you take the traditional models, how do you take the embracing and comfort level now with technology and start to blend them together to be an optimized experience. And I think that optimization works multiple ways. It works for the providers and their staff, but it also works for the patients. So really now we're looking at how do you start to balance how care is delivered, how do you start to optimize how that care is delivered, and there's some opportunities in front of us, I think, to look at quality of outcomes. We're going to talk in some level of detail, but the short of it is that telehealth delivers equal outcomes in terms of quality to in-person care, and there's some opportunities for more cost efficiency, better staff utilization, and certainly, as Kurt noted, we've got the whole convenience factor and how people are looking to engage with their healthcare, just like they engage with other aspects of their life. So from a model perspective, we've got the traditional in-person, we've got the online or telehealth only, and really what we want to start to look at is how do you blend that together? And we will get into more detail later. Certainly there are some opportunities with a hybrid model that were not there before. The concept of on-demand visits is a big one, and there's different ways to do that, so you're not losing complete control in terms of how patients access their physicians and associated staff. But certainly the technology gives a level of immediacy that has a lot of advantages and opportunity to it. And as technology continues to iterate, like it always does, the ability to monitor health and vital signs for not just extremely acute patients, but for the average person is only getting more powerful. And there's a lot of opportunity there for both the patient to engage more fully with their health, as well as for the provider to be able to collect data and interact with that data and provide some more proactive care as opposed to reactive care in terms of health incidents. So as we think about this hybrid model, we're really thinking about arguably a more interactive experience. And we've been trying to solve the patient engagement conundrum for quite some time. But with the utilization of greater communication across multiple channels, that patient gets more engaged and is more aware and has more top of mind what their care is, which certainly can help drive improved outcomes. There's opportunity to leverage scarcer skill sets and resources on the provider side across a broader patient population. utilizing the technology. Certainly in this marketplace, again, as Kurt said, with the physician shortage, that's important that we figure out how to provide as much care as possible to as many people as possible. And as the industry continues to move to value-based care models, really we start to think about what is the cost of this care episode as opposed to, how is revenue being generated by any given encounter. So we'll talk really a bit about all of this as we continue, but certainly lots of opportunities as we think about a hybrid model. So just before we kind of go over to thinking about the staffing side, there's clear benefits that people are seeing with this hybrid model. So one AMN client who provides a lot of care in a rural area is able to cut their placement for obtaining providers and getting them delivering care by 75% by going to a telehealth hybrid model. So that's speeding up time to care, getting the physicians and clinicians available, and of course the patient is getting that care just in time. We also have another client who's looking to go to 24/7 care delivery, and so they're taking an in-person model. They're basically mirroring an off-hours model with telehealth so that they can provide 24/7 care. So the workflow and the operations, it's not a radical change. It's really a complement, but it just expands and scales that ability to provide care when needed for patients with existing staff and resources. So lots of opportunity. And Kurt, I'm going to let you talk just about how these flexible staffing models can go.
Thanks, Mark. And flexible staffing has been around ever since we really put together the medical home model. If you remember, right after the HITECH Act, we had the patient-centered medical home. We have population health in America. But really just not a simple explanation, but a flexible staffing model is just something that adapts to changes in supply and demand. And let's just face it, during COVID, we had such ups and downs in supply and demand. In a lot of cases, it was just impossible to predict that. And why flexible staffing models continue to advance. And I always like to use this, if anybody's a baseball fan on the call today, but Yogi Berra's famous saying, he said, making predictions is really, really tough, especially about the future. It's just hard to predict how and where you have to deliver your healthcare in America. And again, it's centered on the team-based approach. And again, studies have shown that patient-centered medical homes, population health, improves outcomes and it increases access and it really lowers costs. And in America, we want to continue to provide quality, and that's another conundrum. How do we grade healthcare? How do we patient satisfaction scores? All that as Mark mentioned, as we go from volume to value. But again, lowering costs is one of the benefits. It's not the purpose of it, but if we can get to see more people, lower costs, and provide better outcomes, that's the key. And again, as we mentioned, it does lower costs and really helps your providers. Resiliency is real key now, as I mentioned. Provider burnout is prevalent in the marketplace, as I mentioned. In fact, there's so many things that COVID did affect us in the marketplace. One of my neighbors is an internist, and she said I was really burnt out because she lost 2 of her patients. And because of the infectious nature of COVID, the families couldn't be with their patients during their last hours. And she said, nobody could have prepared me for that. So burnout's prevalent. We have to look at that and say, how do we ease the burden on our doctors? And using contingent labor sometimes will help fill those in. And this is part of virtual care, but at the same time, making sure there's other people available when that one provider is at wit's end. And we've also seen that flexible staffing provides more access and specialized skills. So more providers in a smaller area. We're getting out of this siloed approach to delivering healthcare where your primary care provider was the only one that was knowing what's going on with you, bringing in other specialists as you need them. And again, in the future, these flexible staffing models are going to include virtual care because every clinician is going to be required to provide that. And again, organizations adapted it again, but it was beyond the financial benefits. It was more like, how can we be more flexible? How can we be more nimble? And again, it's giving employees more autonomy with their schedules. We've seen so many doctors leave opportunities in America, ladies and gentlemen, because they wanted more opportunity. They wanted to work different times. They wanted to work when it was convenient for them. And again, it incentivizes for retention. You work more tough schedules, more flexibility for you. And we're seeing more and more. The day of the old FTE equivalent of our providers in America is gone. What used to be Geminic, if anybody's been in the business as long as I have, where it was one primary care physician for every 4,000 patients in your service area. Those days are gone because it's hard to predict that. And again, when you bring in telehealth, besides retention, it gives you flexibility for your staff. And again, a lot of people that I know, administrators throughout rural America, said without telepsychiatry and telestroke, they're basically dead in the water. And again, it's that shared decision making due to the changing workforce. And again, this is adapting to what our providers of healthcare are asking for in the marketplace. And just real quickly, I want to go through the 4 different models. There's in-house models, and that's really building up. We've seen this with nurse float pools. We're starting to see it now with physicians float pools, and it's building up your internal and external float pool. Internal is offering, a lot of cases, additional shifts, if you will, or different coverage to your currently employed employees, and also bringing in contingent labor, as we talked about. And again, the per diem shifts will correlate with patients' demands. A lot of hospitals have gone from 95% staffing of 90% of their census to 60%, so they can be more flexible, more limber, if you will. The top of license model, that just means that if we have a nurse practitioner or a physician assistant, let them practice to the extent of their training. We limit that in a lot of cases. Top of license model just means what you're trained to do, let them do. And in a lot of cases, whether it's state regulations, whether it's different regulations, we're not letting some of our advanced practice specialists train to the top of their ability, which can eliminate a lot of the access issues and the need for additional providers. The cross-training model lets people say, don't want to, especially in our internal medicine specialists, they're looking at it and saying, I want to learn new aspects of internal medicine. I want to understand a little bit more about pulmonology, and it's good for knowledge sharing. And then retention model, where it's giving growth opportunities, increased compensation if they want to work more shifts, access to mental health care, and just basically the new technology. It's exciting what the new technology is today for virtual care in America. Mark?
So let's talk a little bit about, what are the functions and features of a telehealth solution. And we all think about the video, and for good reason, because being able to put eyes on a patient has value. In the AMN client base, we have a number of home health clients who are providing wound care over distributed regions, and the HD, even the SD video that people can get on their mobile devices and home computers is adequate to do a lot of diagnosis. So the eyes on the patient matters, and the video matters, but there's a lot more. And so as we start to think about what an effective solution looks like, we're really looking cross-channel communications. We're looking for flexibility to go from one channel to another as appropriate for whatever the topic is. We do this every day in our personal and professional lives, whether we're on a texting app or on the phone, on a video call. Being able to pull all of that together into a single solution to deliver care and communication between the care team and the patient is important. Secure messaging is an important aspect of it. We come across a lot of people who are doing just text messages, SMS text messages, back and forth with patients, which pretty much has PHI and pretty much is out of compliance with HIPAA. So, thinking through what is a long-term effective way to have the detailed conversations that are needed to deliver care, but to do it effectively and securely for everybody's sake is important. So video, but secure messaging as well. We mentioned remote patient monitoring, and certainly there's the potential for some intense equipment in an acute setting, and as we think about the hospital at home model. But part of what's really exciting is in the consumerization of electronic devices, just like it's always been, there's tremendous progress in terms of what's available just to wear on your wrist that can give you all of the key vital signs. You can pick it up on Amazon or at Best Buy, and the consumer probably wants this anyway as just part of their lifestyle. And now here's some very rich, meaningful data that can help the individual understand their health better, but can obviously help the care team to make decisions and deliver care. So we think that the remote patient monitoring and certainly the day-to-day vital signs is going to become increasingly more important. Also within the features and functions is the ability to do large-scale tailored messaging. We live this every day with marketing campaigns from various retail outlets or what have you. But being able to leverage data, generate automatic messages to a patient that have specifics about their health status and their care plan is just tremendous in terms of taking burden off of individuals to compile, make phone calls, try to reach patients. And it's giving a nice, helpful, convenient reminder for patients of conditions, symptom management, next steps in their care plan. And pulling all of this together really starts to become powerful. Included in this sort of integrated set of features should be the ability for secure assessments for a patient, whether that's taking screenings, signing documents, doing some self-reporting. There's a lot of value and a lot of time savings for the care team if the patient is providing that information proactively. And another thing that's important, especially in light of the Accountable Care Act, is language interpretation. So a lot of the population is not necessarily English speaking as a primary language. And then you get into the complications of delivering health care and understanding medical conditions and care instructions. It's critical that an interpreter be available just for the quality of care, let alone the regulations requiring it. And telehealth and the associated technology is perfect. As you can see in the image there, there's a live interpreter in a conversation being brought in on an iPad, talking to the patient, talking to the provider, and making sure that everybody understands each other. So lots of opportunity. And you've heard me use the word integrated a few times in the features and functions. And really, if we're thinking about what is an ideal telehealth solution, how do you start to deliver hybrid care across settings and encounters, whether that's in person or virtual? And we really want to have a unified workflow. And I'm talking unified workflow above unified technology, because I think it's important not just for the technology to be integrated, but for the whole flow and care delivery across the providers and care team as well as the patient to feel seamless. And so you can see some of the features and functions, whether it's appointment scheduling, intake, the encounter itself, the encounter notes, follow-up, all of these things that are happening today, potentially in a telehealth-only setting or potentially in an in-person-only setting. We want that information to flow, and we want the activities and the actions for all parties to be seamless and not complicated. Certainly from a technology perspective, we do need to look at integration. And there's not a one-size-fits-all effective solution in the marketplace today. That may come in the next handful of years, but right now I think the recommendation we would make is, how do you start to look at the least moving parts, and how do you connect those parts so that the data flows back and forth, so that there's only one login experience for the provider as well as the patient, and really lets them move across the care settings so that they can be seeing a patient in person and documenting that, then going and having a video call with them, also documenting it in the same system, being able to look at that history, engage in those follow-up communications. That really is where you're going to start to see a convenient, helpful experience that gets the patient engaged and also creates efficiency, does not create frustration for those clinicians and physicians. So if we think about, what does this mean practically? I'm going to start at the bottom here in terms of bullet points, but we need to go beyond the patient portal. We've had somewhere in the range of 30 to 40% patient utilization of portals since they first got introduced. It's been pretty flat. And there's a lot of reasons for that, but there's a lot of opportunity to not replace the patient portal, but to really supplement it and complement it in a way that gives patients easier, more intuitive access, really gets the communication going back and forth between the care team and the patient in a way that drives convenience and time savings for all parties. So looking for a solution from a technology perspective that brings all of those communication channels together, integrates with other core systems like the EMRs, e-prescribing, et cetera, and allows the data to exist and flow from one system to another, will enable that unified workflow and that seamless workflow for all parts. So let's take a bit of time now and talk about chronic care. So this is really kind of an applied section, if you will. So as Kurt noted, the vast majority of healthcare expenditures is spent on a minority of the population, and the number of chronic conditions is estimated at approximately 50% of the population. Obviously, a smaller portion has multiple conditions, but this is a problem that has existed for some time, and again, continues to get worse as opposed to getting better. And the opportunity with telehealth and hybrid care is to try to move that needle in the other direction. So as we look at the increased availability and the lower cost availability of monitoring devices that an individual can wear, that's going to help generate day in, day out, real-time insight into how any given individual is doing. And the price points are coming down, so for the highest risk patients, I think there's opportunity for this to be cost effective, to actually make sure they have those devices, make sure that those readings are happening and the data is flowing, because now you can start to get a proactive view of that patient. You can start to set up alerts and intervention workflows so that that technology can actually trigger the need for an encounter where before that patient may have delayed significantly and may have ended up at the ED or at least in urgent care if they could get there. So a good set of opportunities to help people really manage these chronic conditions. And I mentioned the ED, ending up in the ED. Consistently, providers are measuring results and seeing results for ED prevention and avoidance. So right here we're seeing an example of a home health agency that had a 23% reduction in hospital readmissions by bringing in this RPM monitoring, bringing in these communications. And that's a consistent story, and I think it's a consistent result in terms of optimization and improvement. So as we think about the different features and functions that we've mentioned, all of these become relevant for helping chronic patients. Being able to have a on-demand secure message conversation, like we all text each other little notes or thoughts. It doesn't take a lot of time, but now there is a more regular cadence between provider and patient, which helps all parties to have a better awareness of the current state, certainly to get ahead of any potential emergent situations, deliver that care more quickly as needed, and prevent things like unnecessarily hospital admissions. So all of these aspects that we've been talking about, and features and functions and the ideal solution, are tailor-made, especially when put together in an integrated way for that day-to-day awareness of one's health, one's symptoms, and keeping those symptoms of chronic conditions at bay as much as possible. And if we think, just in terms of one specific target to go after, again, the results show that this hybrid care and this telehealth, a higher level of communication, really does help avoid unnecessary ED visits as well as readmissions. So making sure the patient understands care instructions, whether that's post-discharge or just day-to-day management of a condition. Not only can you deliver that in a repeated automated manner that's not a burden on the staff and people time, if you will, but you can also do it in multiple languages so that a patient is hearing those instructions in their primary language so that they can understand and be aware of what they need to take care of. And that ability to do on-demand triage, so if a patient has anxiety or has symptoms, being able to reach out and get a hold of part of their care team or one of their care team members to talk through, whether it's audio or eyes on the patient through video, or even secure message back and forth, is going to help identify the situation and get that patient to the right point of care as soon as possible. And that right point of care can be the emergency room if needed, but may not be. And certainly there's cost and convenience savings for everybody if it doesn't have to go to that point. So again, some more statistics. As you see on this slide, these are different case studies, but another post-acute provider reducing hospital readmissions by 35%. With patients who were in their hybrid model, where there was both online virtual visits as well as in-person visits, over against their in-person visit population only. And another published article related to patients being discharged who had heart failure with less readmissions, again, when they were utilizing this hybrid care and really this greater cadence, not higher cost or higher time, but greater cadence of communications and engagement with their team. So there's real opportunity that benefits outcomes, benefits providers, benefits patients. And Kurt and I appreciate the chance to share these thoughts with you today. Lots of, again, different factors in the marketplace serving as a catalyst for this change and really requiring that we move on from the status quo. And there's ways to really benefit everybody, from the providers themselves to the clinicians, as Kurt mentioned, working at the top of their credentials, having more convenience themselves, and for the patients to be able to get access that they don't necessarily have available to them, whether that's specialties like behavioral health or people who might be in a rural situation where it's just not practical to get to a provider. And actually that could be as true in an urban situation as in a rural one. So there's lots of opportunity for this to be a win all the way around. And the technology's there today to support these types of unified and hybrid workflows. So we'd love to continue the conversation. If any of this resonated or triggered some ideas with you, happy to have a call to just kind of understand where you're at, what you're thinking, and kind of bounce some ideas back and forth in terms of opportunities and potential blockers that you might be wrestling with. So you can see my name and email and phone number here at the bottom of this slide. Happy to be a first point of contact and make sure that we bring a unified and integrated AMN perspective to any conversation, whether it's looking at staffing, looking at technology, looking at the care delivery operations. We'll pull together a team for any call that we might schedule. So with that, the content part of the presentation is wrapped up. But we've got some time available for questions, so I'll turn it back to Erica.
Yeah, thanks, Mark. Thanks, Kurt, for such a great presentation today. So we're already got some questions lined up, and feel free to continue submitting any. We'll go ahead and start with this question. What's encryption and how does it work? Mark or Kurt?
Mark?
I'm sorry, can repeat the question one more time?
What's encryption and how does it work?
Oh, sorry. Thank you. So encryption is basically a algorithm, so a mental process or a thinking process to take what would be a clear message and obscure it so that nobody can understand it until it is unencrypted on the other end, and it's now a clear message again. So this goes back all sorts of technologies. There's all sorts of written encryption. These days, when we talk about it in this sense, we're looking at something that's called 256-bit encryption. It's a random algorithm that basically prevents a hacker from being able to intercept a message. So if I sent you a secure message from my browser and you received it on yours, we've authenticated into our respective software. We're looking at that message. But as it was going, quote unquote, over the wire, of course the wires don't exist anymore, but as it was going over the wire in between, it was in a format that no person or other machine could intercept and understand, because we had, in the background, our technology had made sure that that message was private until the right person was able to open it and read it. Hopefully that helps.
Sure, thanks for walking through that one. Next, we have, how accurate and precise are these digital healthcare sensors that we mentioned during the webinar?
So in terms of the devices themselves, there's a range of accuracy, and I think as you're looking at the acuity level of a patient, you're going to want to take that into account. But even the consumer devices like an Apple Watch, you're going to get a decent, when I say decent, I mean you're going to get an accurate oxygen, you're going to get an accurate pulse rate. The cuffs, the Bluetooth blood pressure cuffs that go on your arm are highly accurate. And the accuracy is improving all of the time. So for an average patient, that I'll use our home health post-acute client base as an example, the consumer level devices that are anywhere from $50 to $200 to read these vitals are adequate and accurate for delivering that care. If you get into a hospital at home model, that gets a little more complicated, but that's also such a thin slice or small slice of what we're talking about here.
And Mark, if I can add to, KardioMobile is one of the best devices on the marketplace today. It's one of the top sellers on Amazon. A good friend of mine lives across the street from me. He's a cardiologist, and he said it's really accurate to 9 to 10%, which is really good for any sort of cardiac episode. And that's really, we know in America, third or fourth is, our cardiac disease in America, as you mentioned, the multi symptoms of a lot of our patients in America. And as we get older, obviously our heart health is very important in America, and they've been very useful for getting something pre-episode before it gets into acute event. So.
Next year, an attendee is asking, how should we anticipate HIPAA regulation changes as the use of telehealth increases, and how may this financially affect providers?
So I'll start, Kurt, and you can
Sure.
jump in. But so in terms of HIPAA regulations, I think if you look at the solutions in the marketplace today, as well as at least what I'm hearing and seeing as I look at various technology providers, all of them take HIPAA very seriously. So if we start with the premise and the current state of PHI needs to be protected, needs to be safeguarded, both with the technology as well as with our policies and procedures, the hybrid model doesn't have to compromise any of that. And I think, again, there's consumer level solutions that are in the current marketplace that encrypt the data, as we just talked about before, that don't have to have high CapEx cost, and really can work across the bring your own device paradigm. The key thing is just whatever vendor or solution you're working with, making sure that you've talked through all of those security policies, procedures, questionnaires with them. But it doesn't have to be high cost to stay compliant. In fact, it can be very cost effective, especially if you start to look at other ROI opportunities like we've talked about.
And I think the privacy issues, it's not going to increase dramatically the financial impact on our providers, whether, I don't know if the second part of the question was sort of cueing the part of increased insurance or any sort of malpractice issues. But I know with the ones that I've utilized, it's even hard for me to get into sometimes because I forget my passwords or how to get into. So we don't really see that. We see the benefits outweighing the financial impact.
Sure, and great to hear, as you mentioned, many of these technologies are taking HIPAA seriously. Next here we have you heard much about the concept of a virtual nurse to assist in acute care, as so many nurses are retiring early?
If I can start, Mark, we're seeing virtual care in all aspects, and I think one of the big things that if anybody's a Star Trek fan from years ago, they had virtual care through the tricorder, if you will. But we're seeing a lot of nurses that were formerly doing travel assignments during COVID being part of that virtual nurse situation in America. And as Mark mentioned earlier, it's very important also to have language correlation with that, because in a lot of times the virtual nurses are talking to people that maybe don't speak their language, so to make sure that language situation is taken care of. In fact, I was speaking in Los Angeles about 2 weeks ago, and I didn't know this, but there are 200 languages spoken just in Los Angeles County. I didn't know there was 200 languages in the whole world, so very important. Mark, if you'd like to add any.
No, I just echo. I think we have both acute system and health system clients as well as post-acute that are using this virtual nurse model and are finding it to be effective in terms of as they measure quality of outcomes. Again, the outcomes are at least as good as the current in-person model, and they are seeing efficiency and speed to diagnosis. I can think of one ED supervisor in a health system in the Northeast basically saying, if we can get eyes on the patient while they're at home, we can help direct them to the right center of care for what we're observing, and we can actually get them that care quicker than if they just walk into, maybe the closest emergency room, or if they call 911, what have you. And that conversation was a handful of years ago, and they've realized the benefits as they've put into place these triage centers with virtual nurses. So I think it's being proven in real time. It's not just a theory.
Sure, lots of opportunity with the virtual nurse model. Next question here is, how do you think the impact of internet access affects those in rural or impoverished areas?
Well, let me start, Mark, if we could.
Sure.
We find the majority of the people that do live in rural areas in America, and there's a lot of them. It tends to help them, I guess, to answer the question first. Internet access is very important, but we also find, especially in rural areas, when you have a situation where they say almost 95% of the people have cell phones, the most important part of that is what percent have smartphones, because that's how you access telehealth, and that's the key to make sure. And many hospitals in rural areas have set up situations where they help people with getting access to smartphones, or even having the internet in their hospitals, so people know not only the care they're going to need through telehealth, but the insurance that they qualify for, whether it be CHIP, Medicare, Medicaid. It's very important. The hospitals have been very involved in rural areas to make sure that the patients in that area have all the access they need virtually, and make sure they have the right equipment, if you will, to make sure that they can get what they need in the marketplace. Mark?
Yeah, I think there's still work to be done in terms of internet access in rural areas or even inner city areas. So the job is not done, and the problem isn't 100% solved. But Kurt's right, which is if an individual has a smartphone and they are able to get any sort of data signal, they're going to be able to participate in telehealth. The solutions that are in the market right now are optimized for low bandwidth connectivity, whether that's even with video, but certainly with secure messaging and that sort of type of connection. So there's work ahead of us, but I think it's more of a glass half full than a glass half empty.
Sure. Now, next year with the COVID pandemic health emergency, what do you foresee the impact of the public health emergency declaration ending will be on telehealth practices as it relates to sustainability?
Well, I think going forward, equal pay for our providers, whether it's in person or virtual, has to be equal, and there has to be movement, whether it's our legislative officials or a national decree, to make sure that keeps. Because I think the future of telehealth is to making sure that our providers feel equally compensated for the care they give, and this is the key for them to continue to participate in telehealth going forward. Mark?
Yeah, I think the good news is that CMS has extended the equivalency to some of the public health emergency allowances. We still need legislative codification of those allowances and ideally some expansion in some areas. Good news is that there's bipartisan support for those expansions. The bad news is that it's bureaucracy and it moves slow. So, we're still waiting for, I think, the ideal solutions, but I don't see anything moving backwards. It's just a question of how fast or not fast it moves forward.
Sure. Next question here. How do you handle issues with billing for telehealth when the provider's in one state and the patient is in another and in a different Medicare administrative contractor? It appears to be a big issue with our billing folks.
So I'll start from maybe a solution side, and Kirk can add, is part of when you're looking for that ideal solution, and this is, again, not pie in the sky, it exists today, is to work on a solution that can do routing. So I know as we work with our clients, we work a lot to make sure that rules are set up within the technology so that a patient, whether scheduled or on demand, is routed to a provider who is licensed for their geography. And that can be dynamic based on the location of the provider, and that provider can move around. But there is opportunity to essentially have all of that automated to mitigate some of those billing questions. Certainly, if somebody's looking more broadly or has some broader challenges, we are then, I think, getting into an operational conversation of how do you make sure you have the right staff with the right credentials in the right locations. Again, it's a problem that can be solved, but if staff presence is complicated, then we really do want to get into that staffing and ops conversation.
Yes, I agree with what Mark said, and a couple of my neighbors have provided virtual care to other states were very frustrated in their ability to get paid. And I suggested to my one neighbor, I said, if you try to scribe that specializes in this area, and then I didn't hear anything from him. And then about 3 weeks later, he grabbed me when I was coming in one day, tipped me over his office. He has a sign on the side of his office, and where he delivers his virtual care, and it says "Doctors save lives, scribes save doctors." So that's another suggestion to have that to help them with their building situations.
Thank you both. Time for a few more questions here. So next one is about remote patient monitoring programs. So with the ever-changing technology and best devices, do you recommend a practice start with one vendor that manages multiple devices or multiple vendors that specialize in a different device?
So I'm always going to have a philosophical predisposition to reduce the number of moving parts. So I'll just put that bias on the table, which is if there's a vendor and a solution that's going to solve 60 to 80% of the care you're working to deliver or actively delivering, I would be focused on that. Now, there may be particular specializations that require different equipment, which I'd want to have kind of that conversation maybe more one-on-one to understand the context there. But the less solutions that have to be maintained and integrated, the lower the operating cost, the lower the initial CapEx, and I think the happier the users, the providers are going to be with learning that technology.
Agreed. Simple is better. And you always have the option if the the decision you chose, the direction you went doesn't work out, you have the ability to be very nimble. There are many people in the marketplace willing to help if the situation you're using doesn't work out.
Now, lastly here, how does a health system make the decision between build or buy telehealth solutions? What key points should we consider?
Mark, that's you.
Okay. No, I'm laughing because there's multiple dimensions to answering the question. So I would say, where is either your strengths or weaknesses? So are you struggling with finding the right staff? At that point, I'd want to find somebody to partner with who can help supplement that. Or are you, basically you've got the staff you need to extend those services. At that point, you probably are looking at, well, what's an effective technology solution to enable my staff to engage with my patient population? So there's, again, a little bit more context as to what direction you go. I don't personally, again, this is a bias, I don't see healthcare providers as needing or potentially should be in the business of building the technology. I think there's so many cost-effective, good solutions. Let the technology vendors focus on the technology. You're always going to get the latest and greatest that way. And focus on those care encounters, because that's the key value of why the provider's there in the first place.
And ditto what Mark just said. And one last suggestion I would have, ask for input from your providers, and not just the physicians, the other people that are involved, whether it be a proctor, whether it be a nurse, whether it be an IT specialist. Ask for their input. The people that work with you, ask them for their decision and make them participative in the decision-making process.
For sure. Thanks for those pointers when it comes to telehealth solutions there. That is all the time we have for today. Thank you again to Mark and Kurt for an excellent presentation, and to AMN Healthcare for sponsoring today's webinar. Please check out the resources section on your webinar console to learn more about the content presented today, and fill out the post-webinar survey that's there as well. Thanks again for joining us, and we hope you have a great rest of your day.